Okay, so it's 3 minutes past 2. I think we can start. Welcome everyone to our webinar today. My name is Tarisai Bere. I'm a clinical psychologist and a global mental health researcher based in Harare, Zimbabwe. So I'm standing in today for Professor Dickson Chifamba, who sends his apologies. He's traveling. So I'm going to be the moderator. And our topic today is despair, depression, and suicide, the impact of long COVID and chronic illness in Africa. So we want to discuss how we can cope and come up with some solutions that we can use to try and deal with these issues. On our panel today, we have Dr. Dickson Chifamba, who's a physician, Dr. Michelle Dube, who's a psychiatrist, and Dr. Jonathan Brakarsh, who's a clinical psychologist. So our speakers are going to give us different perspectives on this topic and coming from of palliative care, psychiatry, and psychology. We have 10 minutes for each speaker, and then after that, we'll open the floor for people to ask questions. So I think without wasting any time, I'll give this platform to our first speaker, Dr. Dickson Chifamba. Over to you, Doc.
Thank you. Good afternoon, everyone. I've already been introduced. I'm just loading in my presentation. Can everyone see it?
Yes, we can. Yes.
Okay.
Yeah, we can see them.
I'll briefly put up my video so that you can have an appreciation of whom you are talking to. At least we meet in the streets or somewhere else. And you also acknowledge that you're not talking to a robot. There I am. I'm based in Harare. I'm a palliative care physician. I work with Island Hospice in healthcare, which has got 4 branches in Zimbabwe. I'll switch off my video so that I can improve the connectivity. We do have challenges here once in a while. You can see my presentation.
Yep, we can see it.
Doc, we can see them.
Thank you.
Yes.
So the topic has already been announced, but I'll be specifically focusing on the palliative care aspects. Is it related to mental health as per the topic, but focusing on living support and care for the chronically ill, looking at the family and also looking at the patient themselves. So broadly, hopefully by the time I finish my presentation, we'll be able to appreciate different values and norms within families, living with someone with a chronic illness, and the importance of working with the patient's family in order to achieve a holistic care, mentally, socially, spiritually, and physical health. But before I go into the subject matter, I think some background definition will suffice to make the picture clear to everyone. I mean, when we define chronic disease, what do we refer to? A chronic disease, these are conditions that are persistent in a patient or otherwise long-lasting in its effects. The course of the disease lasts for more than 3 months. You will find that we tend to, before then, maybe just an acute illness, but once it's go beyond 3 months, we start classifying it as chronic. There are basically 2 types: the non-communicable diseases, examples, the diabetes mellitus, renal failure, neurological diseases, e.g. dementia, and so on. Communicable diseases, which is also part of the topic of discussion today, the long COVID, TB and HIV. There is also what is less understood by a lot of people, the chronic illness, which just refers to the personal experience of living with the affliction that accompanies a chronic disease. What you'll discover even in the medical field, my colleagues here, even from the psychologist perspective, psychiatrists will acknowledge this, that sometimes chronic illness is not often recognized in the health system because it does not really fit into biomedical or administrative classification. I mean, someone presenting with mental illness, sometimes it may be very difficult to pick because it doesn't present with those classical symptoms, which can make you define that this is a certain disease. Someone with rheumatoid arthritis or chronic arthritis, which is not really specific, it may be very difficult. And it's very important for us to acknowledge that there are a lot of people who may be living with chronic illnesses but have not been diagnosed. And this presents a challenge because we end up labeling them as psychosomatic or with some other mental disease when they are genuinely ill. Then there's the long COVID, which is prolonged or recurrent symptoms, which can be seen after weeks or months post-COVID recovery. And we usually subdivide this into two: the post-acute COVID, where those symptoms appear 3 weeks, greater than 3 weeks post-COVID recovery, up to less than 12 weeks. Then there's the chronic COVID, in which symptoms persist beyond 12 weeks. I will not go into the nitty-gritty details of all those symptoms, but just for you to acknowledge, because that would be a separate lecture on its own. Then there's the term palliative care. Again, misunderstood by a lot of people. I've tried to use the good definition, but I prefer this International Hospice and Palliative Care Association definition. It was revised in 2018. It's more of a consensus definition of palliative care, where palliative care is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, which can be COVID, especially of those sometimes who are approaching end of life. And the focus is to improve the quality of life of those patients, their families, and the caregivers. For better understanding, when I refer to suffering, is health-related, it is associated with illness or injury of any kind. Because there's quite a lot of misperception, a lot of people, that palliative care is only for cancer or for people who are terminally ill, but it can be associated even with acute illness or injuries. And health-related suffering is serious when it cannot be relieved without professional intervention. And when it compromises physically, socially, spiritual, and emotional or mental functioning. And severe illness, like I said, can be acute or a chronic illness or health conditions that carries a high risk of mortality, which negatively impacts quality of life and daily function, or is a burdensome in symptoms to the patient. It can also cause caregiver stress. So what is the importance of working with families in a palliative care setting? We know that the family is the unit of care for any patient or client. But it is also very important to recognize that a family is what the patient defines themselves, not what you may assume yourself. You may find that someone may not define a very close relative as part of the family member. Maybe a friend is the one who is regarded. You have to work with what the client defines. And by working with the family unit, we ensure that the patient is supported holistically, even in the terminal phase of the illness. And we also aim to keep the family, that unit, functioning in a healthy way. And in any case, it also improves communication. Coming to the really subject of the matter associated with the subject of today, when someone is going through a chronic illness, whether it's long COVID, whether it's diabetes, which is complicated hypertension, or any other disease. There are so many coping strategies which the patients and families who are facing this chronic illness do go through. There are seven dimensions, which sometimes some of these patients and families. This dimension I would want to prefer to call it redefining. I mean, this is someone's going through a chronic illness, depending on the stage. There has to be a shift from what used to be to what is now. Sometimes we do encounter a lot of challenges. People want to stay with what used to be. They want to do things which they used to be. But this requires adjustment in self-perception and of others. You'll find that the patients and sometimes family trying to maintain usual patterns as long as feasible. And patients may fail to redefine where they are with this chronic illness. And this can cause a lot of even mental stress, frustration, anger, depression, despair, feeling of worthlessness. And from the family members, they may also fail to redefine and also get frustrated. I've had patients from experience where they would force a patient, even if you can see that this patient has got long COVID, they used to walk or a jog or whatever, but now they can't. But the family will push, no, how are you going to recover? Please, forcing the patient to do things which they're not capable. And this may end up causing quite a lot of frustration, and they're accusing the patient that the patient is giving up. Burdening is a feeling of burden. Family, which happens in most families when they are taking care of someone who is sick. It can be caregiver burden because of the excessive work they are doing, whether it's 2-hour returns, dressing rooms. And some of these caregivers are not health professionals themselves. So they really face, and they will need a lot of support because some of them end up being depressed, poor coping strategies. And in our scenario, and I'm not sure this happens in other countries, but more so in Africa, where some families, by virtue of circumstances beyond their control, because there may be no other adult members in the family, we end up having what we call child carers, who end up looking after sick adults. I've had experiences of an 11-year-old taking care, a male child, taking care of a mother with a fang-eating cancer of the cervix, and he was the one bathing the mother, doing all those dresses. So you can imagine, if we don't identify such children, what emotional burden, there will be mental burden, and how will those children grow up? So they need support. Also the social burden, which end up causing isolation and feed into the mental stress. So the mitigation factors we really need for that burdening is which is happening quite a lot. Like Zimbabwe, though there may be challenges here and there in terms of secondary caregivers. And from the organization I work with, there's quite a lot of training in the communities of those secondary caregivers. And I know Friendship Bench is, from a mental health perspective, they're doing quite a lot using those community caregivers to support this. Then there is the struggling with the paradox. You know, the paradox stems from the fact that the patient is living, but sometimes they're also dying. And this can really be a paradox because the patient themselves or the family themselves may not want to accept that is what is happening. You can imagine the coping strategies they will adopt, the anger which will come that the doctors are failing. So the patient may fluctuate from shock, denial, anger, bargaining, and acceptance, resulting in different moods, mental moods, which may range from optimism to pessimism. Yesterday, I went to see a patient quite advanced lung metastatic breast cancer with a lot of fluid. You can tell this patient is dying, saturating at around 55%. He was called as an emergency in a home. Instead of preparing the family, this is what was happening, but the family were pushing that the patient be taken to ICU. And the patient was even asking, when am I going to get better? It really becomes a paradox. content. The family member experience changes in every realm of daily life, in terms of the relationships with others. Focus of change may differ among family members. You can also be searching for meaning, tend to seek for answers to help understand the situation. What does this mean? They may become very spiritual, exploring the meaning of life in their current situation. Also, even the family members or spouses tend to concentrate on their relationship with the family, but some may also adopt poor coping mechanisms. The other dimension is living day to day. This varies in families and individuals. Some patients will not accept the situation, like I mentioned, and will vote to fight on. I've had patients who have been seen by various specialists. They would refer requests. I want to be transferred to America, India, or the other countries because there are better specialists there, because they want to fight. And even the children may have difficult coping in that day to day. And also the difficult part, preparing for death, the very difficult process. Some patients continue to struggle in denial. It's acceptable, that's where they are. We have to work from a palliative care perspective. We have to work with them. I always say the soul is strong, but sometimes you find that the body is ravaged by disease. And in my experience, and I think a lot of the audience will agree with me, you've seen some of these patients, even from a medical perspective, you would want to say, these patients are really good, they're gasping, chain stalking. You come after a week, 2 weeks, you find they're still struggling. Sometimes when you talk and really dig deeper, there may be a lot of unresolved issues. So the soul is still strong and believe I can come back and look after my children, look after my wife, take care of the things I needed to take. But unfortunately, the physical aspect, disease is so advanced. There is the aspect after loss of a loved one. Come issues of bereavement. You may have left the patient. You're now only dealing with the patient and the surviving family members. Where we talk about issues of bereavement, again, I'm just browsing through this because it's a topic on its own, even from a mental health perspective, where bereavement refers to the experience of having lost someone close. So you have to address those issues even from a mental health perspective. Don't assume when someone is died, and especially with COVID, the manner, especially in the phase 1 and 2 of it, people just die in isolation and so on. And I know things are slowly changing. There was a lot of bereavement issues and a lot of grief, which is the psychobiological response to bereavement, and whose hallmark is a blend of yearning, sadness, along with thoughts, memories, and images of the deceased person. Also to acknowledge that grief is permanent. Process of mourning, which is an array of psychological processes that are set in motion by bereavement in order to moderate and integrate grief by coming to terms with the loss and reorienting to a world without a loved one in it. Just for you to acknowledge that even I know a lot of countries are still using ICD-10, even here, but when you look at the World Health Organization in 28, you'll find that complicated grief, which is prolonged grief disorder, is now acknowledged as a mental health disease, where there's occurrence of a persistent, pervasive grief response characterized by longing for the deceased or persistent preoccupation with the deceased accompanied by intense emotional pain, which can be sadness, guilt, anger, denial, blame, and so on. And they can even have difficulty in engaging, and if it's not attended to, it may end up causing depression. Even the American Psychiatric Association is also revised in that, and they've added this into their DSM-5. So how do we work with families?
Sorry to interrupt, Dr. Chifamba. I'll give you 1 minute to wind up.
Okay, I'm just winding up. The foundation of working with families lies in being honest, knowledgeable, competent, having respect for people, in willingness to give others time, opportunity for reflection, and with good communication skills and with attitudes of non-judgment, acceptance, caring, individualization, respect, and ensuring confidentiality, we can all effectively communicate with the families. Thank you. I think that's all I had.
Thank you very much. Thank you very much for that presentation, Doc. Very informative, and thank you for reminding us that when it comes to chronic illnesses, we shouldn't just look at the patient, but we should remember the caregiver as well as the children. Thank you so much. So without further ado, I think I'll give this floor for questions. If we have any questions, please raise your hand or send them on the chat platform.
I have a question.
Okay.
Yes, please go ahead.
So I'm Dr. Christine Nezu, a professor at Drexel University in the United States, and most of my career has been to a co-developer of social problem-solving therapy and evidence-based treatment. And we have spent a great deal of time with people with chronic illness and their families in terms of helping them cope. If we were to extend work like that to Africa to provide practical solutions and methods for coping with many of the burdens, the problems, the paradoxes that you so accurately cited, what would be the best way to train caregivers, to train people kind of on the ground dealing with helping these families? Would it be through nurses, through teachers, through community caregivers? What would be the best way to reach people in terms of providing them with practical problem-solving type of training? That was actually, our work was actually used in the original Friendship Bench work.
I'll attempt to answer that. Maybe Jonathan may also assist me or other my colleagues during their presentation. From our experience, coming from a palliative care perspective, it really has to be multidisciplinary. At the primary care level, the community caregivers are very key. I think, like you cited, the Friendship Bench, because they have got easily access, and can pick these cases, like, for example, the young carers I talked about, the children. They will need those secondary caregivers in the community to support them. So you can make it multi-level, targeting the community caregivers, targeting the health professionals, because from palliative care, it really has to be multidisciplinary.
Thank you.
Then maybe from a psychiatric perspective, you've already said you've had experience with Friendship Bench.
Yeah, in the US, we've trained for years a lot of home nurses and people that would be working with families, to work with families and to train them in problem-solving methods to help reduce the stress associated with chronic illness and with heart disease as well. So, I just wondered what would be the best way in terms of you know, of your own area in terms of reaching these folks. What would be the best way to get training to them, I guess? And so you're saying through the community caregivers.
Yeah, the community, obviously, they work with organizations like, for example, Island Hospice works with those community caregivers. I'm speaking from a palliative care, so we can target those organizations which work in those communities, which work closely with those communities, and you partner with them.
That's great. I'd love to be able to participate.
Is that clear?
I'll leave my email out there if
Yes,
anybody wants to ever contact me to collaborate in terms of bringing that to the community caregivers. Thank you.
Thank you.
Thank you, Christine. There's another question from Jonathan. It says, what other models of home care exist in Africa? I think this is coming to you, Dr.
Well, it's actually to anyone who's in our any of the listeners, I'd be interested because we have people from all over Africa. It'd be wonderful to hear as well.
Maybe while people are picking courage to answer, I can speak of Zimbabwe and maybe a few countries I've had experience with. When we talk of models, we have, I would say, basically two types of models of home care. There is some which is, if I may say, civil society supported, but also from Zimbabwe, the government supported, which link quite closely with the ministry. It is both have got their own advantages and disadvantages, because we are talking of people who have just voluntarily. And one of the issues which has come up front is issue, especially in a difficult economic settings. How do you continue to retain them when they have other chores to do? And how do you remunerate them? So I know in the Zimbabwean perspective, the government, maybe through other international organizations, they've got a few numbers targeted, which they commonly refer to village health workers. And those work with the ministry, but there are others also funded, which we call community caregivers. It's one in the same, with different terminology, but they basically do the same work. And some are targeted in certain areas, whereas, for example, from palliative care, they focus more on holistic, cover all aspects of patient care. But we find that, for example, some government are more for malaria programs or certain programs. I would like to hear some experiences from other African countries, if people are willing to share.
Do we have anyone on the call from other African countries who'd like to share?
There was a question from someone, while people they still want to share this. Are there Dr. Chifamba, the big question is the community caregivers, do they exist in Africa? Yes, they do exist. There's the primary caregivers who are mainly family members who are taking care of someone by virtue of maybe it's beyond, they may not even have training, but they find themselves taking care of a loved one. But they're also secondary caregivers whom I've talked about. And in our Zimbabwean context, they do exist. And in a lot of African, I know Ugandan experience. If there's someone from Uganda, I think someone introduced themselves to Uganda. In the palliative care, there's also quite a lot of those caregivers.
Hi, could I make a comment, please?
Yes, please go ahead.
Yes.
So this distinction between end-of-life care for cancers or for cancers versus other chronic diseases, I think that's a distinction that we haven't grappled with so much in many African contexts. But even the idea of end-of-life for chronic diseases, the issue is that people have a really tough time accepting that they have resources, then they want to keep throwing money at it. And that in itself leads to mental health problems for the whole family. But I think it's also because we have a young population, 40% under the age of 15 in many countries. So people don't yet have that experience of trying to manage terminal chronic care, like people who are in end-stage renal failure or people who have respiratory disease, where the decline may be steady but slow. So there's a whole area that we work on with this, but the first step is actually acceptance. So I think that's our issue.
Totally agree. The word palliative care itself, like I said earlier, a lot of people are just associated with terminal. Even my colleagues I work with, they only refer patients, some of them when only gasping. We say palliative care started diagnosis of any life-threatening, which can be a chronic or any other progressive illnesses. And it doesn't necessarily have to be referred to a palliative care practitioner, but even those, whether a clinical psychologist, a psychiatrist, a medical, a nurse, those aspects and concepts of communication with the patient starts at right on in diagnosis. So that you don't seem to be giving up and refer to a palliative care physician when the disease is advanced.
Thank you for that,
Yeah.
Doc. I think I just want to echo on that last statement that you made. I think it's very important for us as practitioners and, healthcare workers to just give information from the very beginning, and to let people know what to expect and how, disease might progress, and some of the emotional pain they might go through. So grief really sometimes starts before the person dies. And these are some of the things that I think we need to be able to communicate from the very beginning. Okay, we have another hand, Wakunkunku.
Yes, Wahungu Caleb from Uganda. Yeah, my brother was asking a question that does, the caretaker takers, exist within the African context, and he was pointing Uganda. And I just wanted to say that yes, the caretakers exist within our communities. Yeah, but I think for some time now, traditionally we really had strong circles of support, specifically that were around providing care and support for the children, especially those who really had we were struggling with the issues of loss and grief. Yeah, but along the way, as communities went on, getting disintegrated because of the wars and economic strains, we find that still quite a lot of within the communities, the care system is not all that so strong, and then we still have really members struggling individually on their own, given the fact that the traditional social support, structures had actually been weakened because of the prolonged wars that we've had, internal, conflicts, and economic stress. So it is an issue really that we are struggling with, especially the service providers trying to find ways of how they can rejuvenate, these traditional systems that were really very strong and provided, the safety nets for its members. Yeah.
Thank you very much for that. I think we have 2 minutes. Are there any other burning questions before we move on to the next speaker?
Tari, can I jump in a bit and set the cat among the pigeons a little bit?
Yes, please go ahead.
Okay, so I think we're privileged in Africa that the extended family is there to provide care through every stage of illness. It's an advantage and a disadvantage, because when it comes to actual physical caregiving, we are there. But it also means the decision making is very complicated. The point where we say we're now going to make a person comfortable and take care of pain only without any more active medical interventions, that point becomes so difficult to get to, because there are so many decision makers who have to all get on board. You can't make a unilateral decision to withdraw care in our families. So it's a blessing, and on the other hand, it can be a hindrance too. That's my experience sometimes in dealing with medical decision making in Zimbabwe. I don't know if that has been anybody else's.
Yes, thank you very much, Dr. Dube, for that. Yeah, I think most of us have experienced that. It's very difficult to penetrate decision-making when it comes to the family structure in Zimbabwe, and I'm sure it might be similar in other African countries. We have another question from, oh, I've just lost the question. Okay, I'll get back to it, I think after the next speaker. I'm going to give Dr. Dube the platform now to present on despair, depression. And after Dr. Dube, we're going to have another question and answer session. So Dr. Dube, over to you. Despair, depression, and suicide.
And suicide. Thank you, Tari. I'll begin with talking about how COVID has had long-term effects on about 10% of people who recover from it. And some of the symptoms can be quite distressing. For example, people develop irritable bowel syndrome like issues, body aches, myalgia, joint pains, sometimes just fatigue, a chronic exhaustion, brain fog, which is almost a lack of clarity in thinking, and of course the usual mental disorders that can occur when somebody survives a life-threatening illness, such as anxiety and depression. And many of the people who recover from COVID actually end up having thoughts of harming themselves on more than half of the days that they are having. And this it's not unique only to COVID. It happens in many viral illnesses such as MERS and SARS, but also in chronic illnesses like cancer. So I thought a good place to begin is with definitions, because when we say despair, it's not actually a DSM-5 diagnosis, but it's something which patients will report quite often. And despair is a state characterized by utter hopelessness. And people tend not to show it. They act right, they say the right things, they put on the correct face, but actually inside the emotion is the opposite. They also tend to have a lot of fatigue. They feel tired. They don't want to get out of bed when they are despairing. And they feel quite a lot of uncertainty and worry about many things: their health, their income, finances, academic and career progression. But with despair, it comes and goes. So it's not a dense state. There are days when they feel better, moments when they feel a bit better, and then there are moments where they are really in the pits of despair. Depression, on the other hand, is the symptoms sound very similar: a low mood, low energy, a lack of pleasure. But depression now is constantly there. No matter what good thing happens, or what successes they have, the feelings of a low mood and inertia, they tend to be there constantly, the whole day or most of the day, for at least 2 weeks duration. Then suicide is a fatal act of self-harm undertaken with more or less conscious and deliberate intent. So there are some gray areas where somebody harms themselves because they are psychotic, but that's not actually what I'm alluding to today. When I talk about suicide, we're talking more about the ones who are of clear mind, but decide that they want to end their lives. And it's not just the final act. When we talk about suicidal ideation, it's actually a spectrum from where somebody is imagining that death would be better, people would be better off, I'm a burden to the people I love, so it would be better if I wasn't there. And it goes all the way through to fantasies, to planning, and eventually the final act. And there are some symptoms that somebody is dangerously suicidal. For example, they start making goodbye gestures, right? Things like giving away their valuable objects, making sure their pets have somewhere to stay or their children are looked after. They do write goodbye notes many of the time, And in this day and age, the goodbye note is not necessarily pen and paper. It can also be on social media. It can be a WhatsApp status. It can be a post on Instagram or Twitter or Facebook. Sometimes that's where people express their intent to harm themselves. So these conditions need to be managed. Sooner or later, everyone is affected by a tragedy. And there's no one size fits all for dealing with a tragedy or a health difficulty or feelings of despair and depression. It's about the individual's natural ways of coping and optimizing those. So we have a toolbox with many instruments, and the person has to try on different interventions and find the ones that actually help them. But there are some global rules for everybody. For a start, you need to acknowledge that you are in a state of despair. Rather than hiding it, rather than putting on the face that people want to see that makes other people comfortable. So you need to give your sorrow words. Otherwise, grief that doesn't speak up knits over your heart and actually makes it break. This is something that was said a long, long time ago in a play that shall not be mentioned, but by name at least. But it has been long acknowledged that the moment you bottle things up and you continue to bottle up feelings of despair, eventually you give up and nobody knows why you have given up. So another important thing is for people undergoing depression or any really difficult situation to connect with others who are facing similar hardships. So one of the things we'll encourage people to do is to try and reinvigorate themselves, obviously with the help from carers. So a simple rule is do the opposite of what your body is telling you. When you're depressed, your body is saying you're tired, stay in bed. But do the opposite. Go outside, walk in the sun for 20 to 30 minutes. You do two things there. You expose yourself to the sun, you start making some vitamin D, you start making some endorphins. All that helps with your mood. And it also creates opportunities for positive interactions. So all those negative thoughts about being a burden or being unwanted, you start getting evidence against them. And actually, it's been shown that gentle graded exercise does help to improve energy, but it has to be done according to what the patient is capable of. You can't go from 0 to 100 in a short space of time. Meditation and yoga are also two very helpful, mindful techniques to help somebody stay in the moment. A lot of times when you are despairing, you are thinking about what if this happens? What if that doesn't happen, right? But if you stop and you're in the moment, it takes away some of that distress. A good example of this, which I was given by one of my colleagues was, do you remember brushing your teeth today? When you brushed your teeth, what did you do? You know, how many minutes did you do it? How did your gums feel? Most of us, when we are brushing our teeth, we're already planning the day. We're not in the moment. So that element of mindfulness is very, very important. And many times, so suicide is very common. It's in the top 3 causes of death of people who are in their middle ages, whether it's in Africa or it's in the first world. You would think that it being so common, we're very good at identifying that somebody is in imminent danger of suicide, but that's actually not the case. People fall through the gaps. Apparently, at least 40% of people who harm themselves have had contact with health services in the previous month, but those consultations did not yield a mental health diagnosis that suggested they would harm themselves. So some of the gaps is because people are not proactively asking about suicide risk for many reasons. Chief among them, at least chief amongst the students I teach, is they are afraid of giving somebody suicidal ideation. They fear that if I ask, then I'm giving the person an idea. But actually, research has shown that You cannot spread suicidal ideation by asking about it. In fact, you give somebody relief. They are then able to unpack what they have been going through, which in Africa, at least in our local context, sometimes it's shameful or stigmatized to admit that you've been having thoughts of self-harm. Sometimes health workers also feel afraid that they don't know what to do. There's nothing I can do if somebody discloses that they want to harm themselves. But actually, that's a misconception. There are things that a health worker can do if a patient is saying they are in danger of harming themselves. So some of these gaps, some of the things a health worker could do is things like safety planning or reducing access to lethal methods of self-harm, as well as activating the person's support system. A safety plan is a brief intervention, 30 minutes to about 45 minutes, where they actually systematically go through ways of de-escalating the suicide risk. So, for example, they need to be able to write down warning signs that they are going into a suicide crisis. Are they feeling more weepy than usual? Is it when they have fights with their loved ones or when their work is not going as they expect? Then you also need to help them in the safety plan to identify internal coping mechanisms, right? What do they enjoy doing? Do they enjoy drawing? That can distract them from these suicidal thoughts, sewing, knitting. Those are very mindful things. You can't crochet. You have to count the number of stitches you've put in. So that can actually distract you from suicidal thoughts. Then obviously they identify their social contacts who in a crisis are available to sit with them, to talk with them in private usually rather than on social media, because oftentimes if you take your despair to social media, it can become escalated. And sometimes you open yourself up to malicious comments. So they need to identify their friends who are available. Virtual contacts can also be done to suit their need. For example, video chatting, if they are in serious distress, if they are in moderate distress, maybe even text messages might be useful. Then obviously reducing stockpiles of medication. Many depressed people harm themselves using prescribed medications. So if a patient is actively suicidal, those need to be removed. Then you also have to help them find coping strategies, plan for them, and how to maintain that stability and mental resilience. So these mindfulness apps have a growing audience. I won't say I've used all of them, but I have used a couple, and I find that it's a good way, a good guided way to become more in the moment and less in the future or the past. So this is just an example of some of what is available out there and is free. You can also help patients learn to do deep breathing. If you control your breathing, you reduce your nervous stimulation, your nervous system arousal, right? You can be in the form of belly breathing, right? It can be in the form of slowing down your breathing by, counting to 3 before during an inhalation, hold it and exhale. It can even be about visualizing what you think is taking place in your body with each breath. Another thing I've mentioned, this is the distracting activities. Sometimes people need reminders to develop routines. So no matter how badly you feel, there are some things which should be in your daily routine. Things like I wake up at 7 o'clock, I do 10 minutes of stretching, I will brush my teeth every day, no matter how badly I feel. I'll take a bath by 8 a.m. and I will eat a balanced diet. If your brain is not getting good nutrition, it cannot recover. So people need to be very intentional about what they feed themselves, how often they feed themselves. But there are also things to avoid. You want to avoid excessive use of alcohol because it's a CNS depressant. It also disinhibits people. So many people at the point of suicide are actually intoxicated. You also want to avoid stimulants such as caffeine, excess use of them at least. Obviously, things that are not good for your health, like smoking, and places that are so stimulating on your senses, like brightly lit malls or shops or these noisy places. During this period, you want to avoid that and rather go for quiet, meditative places. You also want to help patients discuss it with them. How do they intend to harm themselves? Is it easily accessible to them? And who can you contact to remove that means of harming themselves? Now, there's a hidden grieving population because each suicide leaves about 5 to 80 people who are affected by it, which is the nuclear family, we recognize their distress. Many times we don't recognize the distress of their friends or their workmates, their healthcare providers, or even just the community at large. Because sometimes the discovery of a suicide is very, very traumatizing. And many people are affected by suicide. Another way of looking at these numbers is in the last year, 4% of people have been exposed or affected by suicide. And 22% of us in our lifetimes will be exposed to a death by suicide. Unfortunately, it leads to very complicated grief, losing someone by this particular mechanism, because there are feelings of shock. There's quite a bit of trauma, and that blocks the transition from acute grief into the integrated grief, which Dr. Chifamba had alluded to. There's a lot of guilt, shame that people experience after they lose a family member to suicide. There's also quite a lack of privacy. You'll find that in newspapers, it's reported, on social media, it's reported. So all of this just makes that recovery from the acute loss much, much more complicated. And it's not the same for everyone, but many people will experience some or all of the initial shock, right? Which is a bit of a numbness, feeling dazed. This can't be real. There's denial. There's quite a bit of guilt or even sadness, where people start to feel, why bother trying? There can be anger directed at themselves, directed at other people whom they perceive to be at fault for the death of their loved one. And hopefully, eventually, they arrive at acceptance. But we need to learn to support families and friends of people who have lost somebody by suicide. So obviously, social contact is important, and it has to be very sensitive social contact because many people struggle to talk about how their loved one died. So it's more about just checking in. Are you okay? Is there anything I can do for you? Rather than asking for more detailed description of the death or the preceding period before. Obviously, there's a lot of blaming. Sometimes we see it in families where the spouse is then blamed for not having loved the deceased person enough or not having alerted the extended family of this risk in time. So families will need support through that. And after any bereavement, some days will be better than others. Sometimes they feel they've recovered, they are going on with life, and something triggers them, something reminds them of their loss. And families should be prepared for that. Obviously, sensationalistic reporting is not the way to go after somebody passes by suicide, particularly avoiding mentioning the specific method by how somebody died helps to prevent copycat suicides. And it also protects the family from re-traumatization. Then families of people who've died by suicide do need psychotherapy. In fact, in some countries, not in ours, but in some countries, it is mandated that there must be psychotherapeutic support available when they want it, because it's a safe outlet for emotions and thoughts, where they're not going to be judged, where those feelings of denial, guilt, or shame can be interrogated and put to rest, and hopefully to guide them along that recovery process to acceptance. And I think that's what I have for you today. Thank you.
Thank you, Dr. Dube. Very informative and such an important topic to discuss. Also very taboo in some African cultures. How do we even start the conversation when suicide is deemed a weakness or a demon or an evil spirit? I think this will be a good discussion to have with the others. So I'll open the platform for others to contribute. Do we have any questions or contributions?
Yeah, can I ask a question, Tarisai?
My hand is up.
Yes, please go ahead.
Yeah, thank you very much for this presentation on despair, depression, and suicide. I am from Nigeria, and basically, if you've been going through the news, you find out that in Africa, Nigeria is one of the countries that is said to have had a low incidence of COVID-19. But I think the good thing, it has a good and a bad side, because malaria is endemic in Nigeria, most people refuse to believe that it was COVID-19. So their method of coping and not feeling despair, especially those who survived, was that they had malaria. And unfortunately, because of the health system that does not have a lot of structure to deal with people who have COVID-19, most of them died in their homes. That's why we didn't have statistics. But you find out that eventually, towards the terminal stage, you find people struggling with their breath, the oxygen dips, and they are hooked onto oxygen cylinders. Now, in terms of suicide, I lecture in a university, and I did a research on anxiety and depression. You find so many students are depressed, they're anxious, and we had a very bad case of somebody who tried to commit suicide in my university by jumping. But again, I have a worry. My worry is that these young people, we don't stay too close to them. It is their peers who stay close to them. How do we now discover this suicidal ideation? Because it is only their friends who stay very close to them that will know that, in fact, this person is not behaving normally and something might happen. And the problem of availability of this materials they use in committing suicide, like there's a chemical they call sniper. Sniper in Nigeria is an organophosphate that is sold anywhere without anybody stopping you, which they usually use for suicide. So I'm a bit worried. And our mental health is not anywhere to go, nothing to write home about. And these things keep on happening. On the other one about palliative care, sorry, I missed making a comment. You find out that it's women in my communities, it's women who are generally laden with the responsibility of giving palliative care. So much stress on them economically. They also have to provide for the family. So you find that a lot of women might be depressed and have a lot of anxiety. But fortunately, because of the backgrounds, women are not very, they don't tend much to suicide. They might be depressed and it will affect their work, and nobody helps them. Let me say nobody helps them. But if you observe it, you can help the person, talk to him or help. in terms of with the palliative care and so on. So that's what I want to say concerning that. It's unfortunate, but I believe that maybe we'll get somewhere someday. Thank you very much.
Thank you for that contribution. Dr. Dube, would you like to comment?
Yes, Tari, thank you. So let me start with the availability of lethal means, the ready availability of lethal means. That is so common. Even here, you find insecticides, organophosphate insecticides are sold at the street corner, which is a very common method, or these cotton pesticides in the farming areas as well. I think that is a legislation and policy issue that eventually, as we try to reduce rates of suicide, needs to be addressed. I think also destigmatizing, talking about feelings of distress, putting up at universities information where children can get help. Sorry, let me not call them children, students can get help. Awareness campaigns. We know first years at university struggle quite a bit to settle in. We know final years are under a lot of pressure. We probably need to build into the curriculum some sort of wellness teaching.
Sorry, just one final question, I'm sorry. And Dr. Dube, do you think that the GPs aren't referring clients that probably need psychological help and probably maybe treating symptoms? You know, like where you've probably maybe got high blood pressure, shouldn't we be interrogating, you know, that aspect, or probably maybe they are not sleeping? Are we not just dispensing sleeping pills when probably maybe they need psychological help? Thank you.
Okay. I want to think that not every patient with a mental disorder needs specialist referral. Considering how few specialists we have, including the clinical psychologists, I think we actually should be task sharing with the general practitioners that they at least initiate and treat those people with mild mental distress or disorders. So they're not actually remiss to be treating it. That's the best way to do it. Community care early on always gives the best outcome. For those, in my experience, when they perceive that the needs of the patient are beyond their scope of practice, the GPs in my area are very good as well as at escalating care for them. The multidisciplinary team, I think, also has a place for a generalist, right? Where we discharge into their care when needed. They refer up to mental health services when needed. But every general practitioner, and when I say that, I don't mean doctors only, the nurses, the occupational therapists, the physiotherapists, all of them have received some level of mental health training, which I think they should be initiating at that level. So if your GP is starting you on treatment, I think it's a wonderful thing. They're doing what they were trained for. And then they escalate when the patient is not improving.
Okay, thank you, Dr. Dube. I think we're running a bit out of time. So I'm going to give this chance to Dr. Jonathan Brakarsh presentation. Prosper, I see your hand. I'm going to give you the chance to ask after this presentation. Thanks. Over to you, Jonathan.
Okay, Tarisai, since it's 3:15, I guess I'd like to put a question to everyone. I can either do this presentation as a separate presentation another time, or it means that people are going to stay a bit later. So I'd like to hear from people about what they prefer. Do you want the presentation, but it means you're going to be staying past 3:15, or should we just schedule this presentation for another time and we can continue the discussion we have?
Go for it, Dr. Brakarsh. will stay longer.
Okay. Other people?
Yeah, I think the boss is happy to stay.
Okay.
It's
great.
okay. You can continue.
Okay, great. Okay, so
you can continue.
Okay, great. Wonderful. Thanks, everyone. That's great. Okay. So what could everyone see me? I assume I'm on video now, yes? Okay. So what we're going to talk about today is long COVID and chronic illnesses, about specifically overcoming despair and depression, how we do this on an individual level, and what strategies we can use, and how do we change our relationship to illness and the feelings and thoughts that it provokes in us. So, okay. Whoops. Now I have a problem. It's not moving. Hold on. There. Oop. Hold on a second. Sorry. Okay, good. So we have long COVID and illnesses, and here are the symptoms and their impact. Can everyone turn off their videos? Thank you. So we have fatigue, we have depression, we have anxiety and despair, and usually the question is, will I ever get better? We have suicidal thoughts. Let me just end it. I can't go on like this. And it was interesting to have Dr. Dube talking about suicide, because I think what I've found is people have different reasons for suiciding, and it's important to find out what those reasons are, so then we can respond better to their suicidal thoughts and impact. Obviously, with chronic illness, a lot of times it is just, let me just end it. I can't go on like this. Sleep problems, and then PTSD. And what happens is the illness becomes the trauma. And these symptoms impact our ability to work, to study, to manage finances, to make decisions, to care for our family, and to socialize. So it's a very global impact on us. Oops, sorry, one. So I saw this on one of the groups, and I thought it was very good description of depression. What does depression feel like? You don't want to live, but you don't want to die. You make plans to do everything, but are exhausted, so end up doing nothing. You don't want to talk to anyone, but you feel lonely. You wake up in the morning and simply wait for night to come. And I'm wondering if you or anyone you know has had depression like this, that this description resonates for you. Can you just write yes in the chat room? Because that would be very good to see that. I think it describes an experience that many of us have had, especially those who have had chronic illness. So, do not feed the wild animals. Our feelings are like wild animals, right? They roam freely and have immense energy, despair, anxiety, etc. They can be unpredictable like wild animals. They're overwhelming, they're even dangerous. So why are we feeding them? Why do we feed our feelings? Just want us to think about it. So for example, how do we feed our depression with negative thinking? Do we really need to feed the wild animals in us? And how can we do otherwise? And we'll discuss this in a few minutes. So how do we create a different relationship to our feelings so we are not controlled or overwhelmed by them? And this is what we need to think about as we do our talk together here. In the heat of the moment, our willpower and ability to reason melt. So how do we make sure that we're not overwhelmed by our feelings and that we don't act out in ways that we regret later? And I think I don't know that everyone can see this because for some reason I can't see my video here. But this candle was totally straight 3 days ago, but because of the heat, it's now bent. And that's what the heat of the moment can do. It can bend our willpower and ability to reason. It can melt it. So we really need to look at how do we create different relationships to our feelings and our thoughts. So that brings us to fly, which is basically a way to have freedom from despair and depression in our lives. So F is for focus, L is for live, and I is for identify. So let's go to the next slide here. Oops. Sorry, everyone. Just trying to get over there. Okay. So in the focus stage, sometimes we have the feeling of stop the world, I want to get off. And times that you're feeling overwhelmed, just stop. Notice what's around you. And what helps is to simply name 3 things you can see, 3 things you can hear, 3 things you can touch and touch them. This is what grounds you. Now you try it with 2 things. 2 things you can see, hear, and touch, then 1 thing you can see, hear, and touch them. And then how are you feeling now? So all of you can try it quickly if you want, and just to sort of see what that experience is like. So those are the times when we just feel we can't take it anymore. And we have to stop the world. The world won't stop for us. The other issue is to breathe. So it's about taking 3 deep, slow breaths in and out. So you're breathing in, nice and slow out, breathing in again, nice and slow out, and breathing in again. Nice and slow out. And then ask yourself, what do I need? Okay. And then finally, every day we need deep relaxation, and video games don't make it. They drain our energy. So once again, it's doing that deep breath in and out, and then doing progressive muscle relaxation, simply tensing and relaxing your muscles from the top of your head, doing that. So it would be like I'm going to make a funny face, but it's first kind of tensing up these muscles, then tensing up your face and relaxing it, then tensing up your chest, relaxing and going all the way down your body, through your arms, your legs, your feet and toes, and then breathing in and out deeply. Okay, and this lovely feeling of relaxation comes. So that's the first step. Whenever you feel overwhelmed, whenever you have a strong feeling inside you, whether it's despair, depression, anger, anxiety that won't let go. The next step is, how do you feel at this moment? So everyone just take note. How are you feeling? Okay, you can write it in the chat room. You can just think to yourself. So now think of a time you did feel hopeless and despairing. Okay, you got it. Could be from any age. And now remember a time you were content or smiling. Do you see that negative and positive feelings never stay the same? You may think this despair or hopelessness will feel this way forever, but feelings are always changing. Very, very important, because when we're in the grip of depression, suicide, anxiety, anger, we think we're going to be this way forever. But they always, always change. Even a person in the depths of deep depression, if they do a graph of every, let's say, half hour, they'll see that it differs during the day. Perhaps the morning and the evenings are most difficult. The other thing is, when we have negative feelings, we usually either want to embrace them or we want to run away as fast as we can from them. So it's very important to just accept your feelings and say hi to them. And I want to read a poem called The Guest House, which some of you may know, by a poet, a Persian poet who was born in 1208. So it's what, 913 years ago. And his wisdom still applies for the ages. So it's called The Guest House. This being human is a guest house. Every morning a new arrival, a joy, a depression, a meanness, some momentary awareness comes as an unexpected visitor. Welcome and entertain them all, even if they're a crowd of sorrows who violently sweep your house empty of its furniture. Still treat each guest honorably. He may be clearing you out for some new delight. The dark thought, the shame, the malice, meet them at the door, laughing, and invite them in. Be grateful for whoever comes, because each has been sent as a guide from beyond. So this is a whole new approach, right, to our feelings and thoughts, to basically accept them and even perhaps learn from them. So I just wonder, and you can put it in the chat room, how many of you have had that experience, where when these very powerful, especially negative thoughts and feelings come, you actually learn from them or welcome them? I think a very important thing is you are not your feelings. You only produce them. Okay, very important. We produce our feelings. We are not our feelings. So that's why it's important to be able to step away and just observe and not be sucked in, because that's what your feelings are trying to do, kind of to suck you into the party. And we don't need to do that. It doesn't benefit us in any way. The other thing is, if you want to be playful, some people find it useful, I know when I'm treating people, to give their feeling a name, a shape. You have it sit somewhere in the room. You can have a conversation with it. And this is a way of getting distance on your feelings. So let's say, like, I don't know that you can see this, but like, sad Harvey, why did you pick me? Why do you come at night when I'm trying to sleep? You can ask it questions. What have you come to teach me? And you can have a dialogue with your feelings, and that way you have a little more control over them because they're outside of you. And instead of the feeling eating you up inside, you can have someone else eat your feelings and your pain. So you can create an avatar. It can look any way you wish, or you can use a puppet. I don't know. Can everyone see this? Here's a crocodile. And this avatar, this crocodile, loves to eat feelings and pain. And as you pass each bit of pain and painful feeling over to the avatar, say aloud what you're giving to the avatar, and you'll feel lighter and lighter. So I might say, okay, avatar, I have a pain in my back while I'm talking. I'm giving it to you, and you eat it. Yum, 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 yum. So you can imagine the avatar, or draw it, or use a puppet. So some people find this very helpful because it gives them some power over a situation in which they often feel powerless. I think an important thing is, does your mind always tell you the truth? We automatically believe that our mind tells us the truth. We react to life, pain, and illness based on our experiences and beliefs. But are our beliefs absolutely true? That's the important thing. And here's the truth test. Think a belief you have about your life. Is this belief true 24 hours a day, 365 days a year? Has that belief always been there? Ask yourself, right? Because what was the belief you had before it, perhaps from childhood? So our beliefs are always changing, yet we take them as concrete. We take them as absolutely true and real, yet they're changeable. So the question is if you change or challenge your beliefs, you can reduce your suffering. We have some control over how much we suffer. And here's what you can do. Notice what you're feeling, for example, a fear of abandonment. Ask yourself what is happening now to activate this feeling. And then finally, is what I'm feeling really happening? So in my state of anxiety, I might think people are going to hurt me or fail me or do something harmful to me. But is that what's really happening? Okay, so our mind does not always tell the truth. It needs updating of its software. It's limited in how it interprets things. And I'm sure you've had the experience where 5 different people witness an event and they have 5 different interpretations. Your mind is constantly interpreting things based on sort of a heuristic, based on an algorithm that never gets updated. And we need to really challenge our minds so we can update our software. John Kabat-Zinn, who created mindfulness-based stress reduction, says pain is inevitable, suffering is optional. So just think about that. Pain is inevitable, suffering is optional. Okay? We have some control over how much we suffer by how our thoughts and feelings and how we react to them. So getting better is the balance between accepting your situation, not resisting it, not making judgments of good or bad about it, because those actions create tension and unhappiness. So it's the balance between accepting your situation and an attitude that you will seek better health. Okay, very important. You're doing both at the same time. And part of the fly approach is live. We've done focus and now we're doing live. So something that Dr. Dube was saying, do one thing that either calms you, comforts you, or excites you. Okay? If there's nothing, then do the things you used to enjoy or that you currently enjoy. You can also make a list from easy to difficult, the things which you can do to boost your energy. For example, Listening to an audiobook might be quite simple. Chatting with a friend on the phone might be more of a reach than you're able to. So make a list of what's easy to difficult to do in terms of getting more energy and living. Okay, because sometimes when we're sick, we get so involved with our sickness and our symptoms, we forget to live. And what's essential is we need to live. Even the process of dying, we need to live while we're dying. We need to do the things we need to do, whether it's saying goodbye to people, whether it's communicating wisdoms to people. Okay. And finally, the part of fly, FL, and here's I, is identify. And this is very important. What are your expectations of yourself and this illness? And it might be even interesting to write it down now. What are your expectations of yourself and this illness? The next thing is, what do you have control over in your life? It's really only the present moment, right? That's the only thing you have control over. So why do we spend so much time thinking about the past and the future? That can change in an instant. So perhaps make a list of what you have control over and what you don't have control over. Okay? And then you know how to distribute your energy, because when you have chronic illness, our energies can be limited, right? I've had chronic fatigue syndrome for 20 years. It's mostly in remission, but it flares up. And I had it acutely for 16 months. And I had to make decisions every minute of every day of how I was going to use or distribute my energy. The other thing is, as part of identify, is who is this happening to? Me. Where does this me live? Who's this me? And what happens if there is no me? If we no longer identify with our illness? What happens then? How is our experience different? What if we just say, this is happening? We step back from our emotions and our thoughts and our experience and just observe. And finally, as part of identify, it's negative mind habits. So let's look at our negative mind habits. These are the habits that feed despair and depression. And there are lots of them, but I just took 4 or 5 as an example. All or nothing thinking. If everything is not perfect, I'm a failure, right? If I'm not fit and ready, and I can't even play with my kid, I'm a failure. All or nothing. That's not how the world works. Overgeneralization, generalizing from a single negative experience and expecting it to hold true forever, right? In the 3rd grade, my teacher told me I was useless, and it's been true ever since then, right? Where we take some defining negative experience in our life, their life. And then finally, shoulds and should nots, where we beat ourselves up, even if you don't live up to your rules or expectations, right? So I should be able to beat this illness by now. Really be kind to ourselves. Eliminate should and should nots from the way we think about the world. And then there's the negative filter. We focus on the one thing that went wrong rather than all the things that went right. My blood pressure is too high, but all the other tests show improvement. So this is very important, because when we're feeling vulnerable, when we're feeling ill, it's very easy to focus on the thing that went wrong. And finally, emotional reasoning. The way you feel reflects reality. I feel like such a loser. Everyone must think so too. Our feelings dominate our thinking. So we need to be aware when we feel a certain way, we're going to have thoughts in line with that thinking, but it's only a feeling. And therefore our thoughts are an anomaly. They don't reflect reality. Okay? So it's very important to have someone give us a reality check. So finally, in summary, if we change our relationship to the illness and the feelings that come with it, we can change how we live our lives. It means less suffering, improved coping with challenges, and more moments of joy and appreciation. Okay? Very important to change our relationship to the illness and the thoughts and feelings that come with it. That's our challenge. And then that affects how we change our lives. Finally, thank you. Thanks a lot, everyone.
Thank you, Jonathan. This has been very therapeutic, at least for me. Pain or no pain, I think this was quite refreshing. And it was quite good that you came at the end. My take home, I think pain is inevitable, but suffering is optional, and that I am not my emotions, I only produce them. Thank you very much for that. So I'm going to give Prosper a chance to ask questions, and yeah, if anyone else would like to ask, we just have 2 minutes because we've really run out of time.
Yeah, what I want to say,
Prosper?
please, can I get this slide on in my email? Is it possible?
Yes, all registrants will be sent slides and a recording of the webinar.
Okay, thank you very much.
Prosper, would you like to ask your question?
It's okay. I wanted to sort of ask if there are any options of someone getting help apart from the current arrangement, especially in the context of Zimbabwe. Someone wants some psychological help and does not want to receive psychiatric help to be forced onto medication. I think that's my concern. Is it possible for someone to get help in a public institution without them receiving psychiatric treatment? Because some of the options with depression and suicide, someone would want to talk to someone, but without them being initiated or being put on drugs. Are we moving towards that, or do we have something like that in our public institutions in Zimbabwe?
Okay, well, I can answer from my point of view, and maybe Michelle can answer from hers. Basically, you can go to a counseling center, and you're going to see counselors or social workers or psychologists who will evaluate whether medication is needed. And medication is only needed if you can't function, if you're so impaired in your work or home life that you're unable to function. So therapists would first start with therapy. If you are a constant threat to yourself, then medication might be considered, but also perhaps they can put you in an environment where you'll be safe. And then they keep working on what the issue is, because often, as I mentioned before, when a person's suicidal, there are reasons for it. And if those reasons can be addressed, the person won't be suicidal anymore. If a person's depressed, there are reasons for it. And if those reasons can be addressed, maybe the depression lifts. Like a lot of people with chronic illnesses have what we call learned helplessness type of depression, which means that they've tried everything and nothing is working. So they just kind of give up. So it's a very different kind of depression. And so if you can find ways to help them find solutions or feel at least they're moving forward, at least incrementally, sometimes that depression can lift. Thanks.
Thank you, Jonathan. I think I'll give this time to you, Jonathan, to just give us the final remarks.
Sure.
To all presenters, and thank you everyone who's joined.
Right. So thank you, everyone. This is a series of seminars on long COVID, and we've extended it today to other chronic illnesses because, of course, the symptoms are very similar and the challenges are similar, and all the presenters did a beautiful job. And next year we'll continue, and we welcome you to send us topics of interest. Please do. And I think if you can put contacts, Biggie and others, there you go. They're appearing now on the chat room. We have a LinkedIn group for health professionals. We have a Facebook group for those of us who have long COVID where we can support each other. And then I don't know whether, do we have an Amari email that can be put up as well? And it'll be sent to you anyway when you receive the recording and the slides. So if you have any questions, you can certainly
sharing your screen.
A screen. Oh, good. Let me do that.
And then I can
there.
share.
Okay, wonderful. Okay.
Okay.
There you go. Fantastic. Okay, so thank you, everyone. And please join us in the new year. And please send in topics of interest. We would really appreciate it because we want this to be as interactive as possible. Back to you, Tari. Thank you so much.
Oh, Tari, you're on mute.
Tari? Yeah.
Sorry. Yeah, I was just saying thank you to everyone for joining us, and thank you, the Friendship Bench and Amari, for making this possible. See you next year. Bye, everyone.
Thank you, everyone. Have a good day.
Thanks, everyone.
Thank you.
Thanks for a very lively discussion.
Bye-bye.
Many thanks.